First, introduce our panel of experts. You already know Dr. Oetting, and to Dr. Oetting's right, we're going to have Dr. Maria Aaron from Emory University in Atlanta, and another experienced surgeon, Dr. Alan Crandall from the Moran Eye Center in Salt Lake City. I thank you all for being here, and we'll start with you, Maria, with one quick question about what specific habits do you recommend for early surgeons to develop to continue innovating as surgeons? Not doing the same cases you did as residents, but expanding your portfolio. How does a junior ophthalmologist do that?
Well, I think there are some obvious things. You can easily attend meetings like you are today. The Academy meeting has lots of courses. And it's important to get some hands-on experience, so not just sitting in the lecture hall, but also doing some skills transfer courses. There's lots of journals and online videos, and if you're allowed to talk to your pharmaceutical reps, they're always helpful in giving you some ideas and new techniques.
You mentioned online. These are young people. They really key in. It's part of their DNA, online. So what are some online resources that young surgeons can use to find techniques? Where are they going to start? Other than Wikipedia, where are they going to start?
Go to Tom Oetting's site. He's got lots of videos. There are some good YouTube things. You've got to be careful, though, because some of those are not as good quality. But Tom Oetting, I'm sure, has lots of good resources on his website.
How about the Academy as well?
And the Academy.
Oh, that's right. The Academy has stuff.
The One Network has
the
lots
One
and
Network.
lots.
Write it down.
Of course.
Excellent. Okay. Alan, how about you?
Well, I think also ASCRS has an iTube, which is, of course, the AAO. The other thing I think is critical. He mentioned correctly that you should video your cases. The issue, though, is you should look at the cases. You not just video them, but look at them. Look at ways you can improve. You know, the thing about cataract surgery is there is no inconsequential step. So you should look at your stab. You should look at your incision. And if you're just starting, I would suggest if a mentor, maybe somebody to come in to help you, to watch and also to say, you're ready to do this, move on to the next step.
You lead us so smoothly into the second question. Because we talk about the mistake has already happened. Let's take a few moments and think about how to prevent these mistakes from happening to begin with. So we'll go back to you, Tom, all right, because Alan already has the answers. We'll come back to Alan for the approved solution. But we're going to put Tom in the hot seat. And so before all these mistakes happen, what do young surgeons need to do to avoid them from happening?
Well, I think first off, they're going to happen. So you need to be prepared for what to do when they do happen. But I think there's no time, I think, when I don't look at video. I mean, I'm always looking at video before, even though I've been doing this for 20 years, the night before surgery, I'm always looking at video. I'm always thinking about, sometimes it's my video, oftentimes it's other people's video, trying to visualize the case. Particularly if it's a tough case I'm doing the next day, I'm sort of imagining myself doing the case, I'm imagining the case go well, and I'm watching video to help me do that.
Okay. Back to you, Alan. I wanted you to talk again about, because I'm an old staffer as well, the stepwise progression. All surgery is a series of steps from the moment you scrub your hands. And if that step is lousy, then there's no way you can make the next step any better. Please follow on.
Well, I think, first of all, to go ahead with Tom's quote, first of all, the only way you're never going to have a complication is to not do surgery. So you have to be prepared, right? The thing I also do is I talk with my retina folks beforehand. So if I drop a nucleus, they say, this is not an emergency. Explain it to the family. Clean up the front of the eye. We'll take it out 2 or 3 days later. Do your part today. So you need to have not only what to do, but also you need to know what your partners and your other players want to do. And if they're accessible, they might come in and say, this is good. So I think that's really critical. But the thing about the incisions, every little part, so what I like to do is if they make an incision, I say, now why do you think that's a mistake? And because it forces them. If it's too steep, it's going to leak. It's too flat. It's they can't get the second instrument. If they make the incision because they've had LASIK and it's a short incision, then that's going to leak, or too long and you can't get the rexus. So I think if they stop and look at every little piece along the way, your partner, your mentors should be able to do that for you. pick it apart as you're doing it.
Maria, before we get your follow-up on this, again, any questions, use the Twitter AAOYO hashtag, and, or just grab a mic. So, Maria, about you instructing residents and how to prevent these mistakes. Let's just call them the avoidable mistakes. What do you do?
Well, I think it's important to, as we've mentioned, be prepared. So if you know ahead of time a patient's got pseudoexfoliation or, you know, a small pupil or something, be prepared for that. Put it in your notes. Make sure that you're aware of that before you sit down at the operating microscope. I think it's also important to tell the patients, because if they have a general idea that perhaps this is going to be more complicated, if there is a complication down the road, I think it's easier to deliver that message later. If you've said ahead of time, listen, you remember how I talked to you about this thing called pseudoexfoliation? Well, that did cause some difficulty during the case.
Wonderful. Have you all been to some of the great restaurants here in Las Vegas? I hope not. They're really expensive. Instead, get your free steak dinner at some of these CME satellite programs. Yeah, that's right. You shouldn't have to pay for a meal at all the whole time for the academy. But when you go, they will introduce you to new concepts, new therapies, new medications, and that's right, new technology. So we want to shift the conversation now with these experts to the whole concept of new technology, and in your new practices, how do you make the leap from doing something the way you always did it, because Dr. Lloyd made you do it that way, to learning new ways because you had a steak dinner at the academy? No, because it leads to better patient outcomes. That's why. We'll start with you, Maria. New technology. Oh, we have a cutaway. Yes, please.
First question of the morning.
Breaking news.
So if you're going to try a new technique for the first time, like a sutured IOL or something, do you recommend talking to that patient that you are trying a new technique on them, and how do you kind of cover that?
Great question. It's a great question. I tend to be pretty honest and upfront with my patients. In fact, I just saw a patient that I put in my first toric IOL, and he came and sat in my office just last week and goes, I was your first toric IOL. And I told him, I said, you know, this is the first time I'm doing this. I feel better if I've told them up front that, you know, I'm going to have so-and-so with me to help me. You know, this is not, I've had courses, I feel comfortable doing it. But I think that you feel better if you're honest with yourself and you're honest with your patients.
That was an amazing question. Was a free ticket
Free
awarded
ticket
to the
for
party?
Elizabeth from Wisconsin. Excellent.
Wonderful. Back to new technology. Tom, before you say anything, when you mentioned, I tell my patients, but you also do it in the context of the bookends, though, of this is something that fits into what I've been doing all along, and I'm quite experienced at it. This is just something newer and better. Would that be correct?
Yes. I mean, make sure that you give them confidence, too. You don't want them to feel that you're not capable of doing it. So,
one of the Wright brothers. Exactly.
Yes.
Right. So, Tom, new technology for new doctors.
I think there's a couple of interesting things Maria said. I think number one is that you're making a slight transition from what you're already doing, and I think that's really important when you're trying new stuff. You don't try a new lens, a new knife, a new phaco machine, you know, all in the same day. You're gonna make a minor transition to your current procedure, like going from a SNWF to a toric lens. And then when you tell the patient, you say, it's just a little minor difference from what I'm used to doing. I'm highly skilled in surgery. I want to do this little extra thing. And the other thing that Maria said, I think, which was really interesting and I think very important, is there's nothing wrong with asking one of your colleagues to come and be with you. There's nothing like having somebody else in the OR with you, another set of eyes, another set of hands, another set of ideas. And it also gives the patient confidence that you're trying to do everything you can to keep the risk low for this new thing that you're trying.
Twitter alert, Twitter alert. We've got our first Twitter question. And Alan, what's the best way to practice new surgical steps or even old surgical steps outside of the OR?
Well, number one, I guess, going back to the video concept, looking at something you think you need to alter. And then you can either do it in lab settings. We have practice labs for the residents. I think if you're in private practice, you can get on, let's say, YouTube and find out. Somebody will show you how to make a fake capsule, and you can practice a new capsule rectus or something like that. Or contact your local academic center and say, do you guys have a computer? We can play with this.
And don't underestimate the positive role of the local vendors.
Correct.
The representatives, the surgical instrumentation reps, can be extremely helpful.
Yeah, just to that point, I mean, whenever you're trying something new, almost always, if it's a new, phaco handpiece or something like that, the reps are there and take advantage of it. They generally know the physics better than you do.
I just want to say that I think the one technology that's useful in the setting of a private practice or being away from the academic center is our Kitaro eyes, because it's only about $3,000 or $4,000 for the setup, and then it's only about $40 for each of the artificial eyes. But the cool thing about the Kitaro system is that you can bring it into the operating room that you actually work in. And so you don't have to have a wet lab, you don't have to have a separate phaco machine. And so it's perfect in my mind for somebody that's setting up outside of an academic center.
Maria?
And the vendors, as you mentioned, are really quite helpful. We just brought in a new femto, and that rep is willing to she wants me to be successful, so she's willing to come and teach me everything I need to know. And if you're putting in an eye stent for the first time, those reps know how to do the wet labs. They will set it up for you, and they'll come help you for your first 10, 15, 20 cases. So, even if they say you only need to sign off for 10 cases, they'll come for 50 if you want them to.
I just want to mention that all three of these physicians are hiring. So if you're looking for a job, please come up to them during the break. And when you do, they're going to be giving you advice right after you sign the employment agreement. Maria, what advice are you going to give to your newest surgeons?
So I think the hardest thing is, as Tom was saying, you're in a new environment, right? And you want to be successful, but you are going to have mistakes. I mean, I still have mistakes, but they happen more frequently when you're a brand new surgeon. So first of all, I think try to avoid, I've seen it plenty of times, overconfidence and underconfidence. And I've seen both of those things, and neither one is really good, but having the appropriate degree of confidence is important. The overly confident people have a mistake and just blow it off and tell the patient, oh, you moved during the surgery and it wasn't my fault. And then the underconfident surgeons are the ones that can barely get back into the operating room because they've had a complication. And so, I think that having good mentors, people that truly care about you, that are not in it for themselves, that want you to be successful, confide in them and tell them, about the complications. They will help you understand what things you could have done better and what things you shouldn't be blaming yourself for, because sometimes things happen and they actually weren't your mistakes. So avoid overconfidence, underconfidence, and have the right level of confidence.
Tom, your new employee, what are you going to say?
I'm going to say welcome. I'm going to say be nice to the chairman. Do what the chairman tells you to do. No, I think what you said at the very beginning, Bill, was excellent. And that is that you have to evolve into the culture of the new practice. And you have to resist the urge to try to change that too much. I do think it's important to have a set of instruments that you're used to when you're starting your first cases, and we certainly will buy new instruments for a new surgeon that joins. But I do think that there's some things that don't change about a practice, and trying to embrace the new culture, embrace the work ethic of the practice is very important.
Well, the other thing I think, too, is we try to make it very collegial. We just say, look, if you have a question, give us a call. We're happy to answer. We'll help you if we want to be there. If you don't want us there, you're good enough to do it by yourself. And so I think that's important, too, is if they need you got to be there. If they don't, let them go. They're free.
Since instrument lists were mentioned, the YO website has multiple lists of getting started instrument sets for cataracts and other operations, and the things you're going to need from your residency to your practice, all the little things that you have now during your training won't be there at the new place you go to, and you have to think ahead of time, checklists, etc., and all that kind of information is in the YO website.